Thank you once again so much.
Thank you,
So,
Eduardo.
so this is OC Tuesday, the International Special Edition. We now have Alessandro Feu to share his expertise in face OCT and ophthalmology. Whatever, what else you want to share? You can share your screen and start your presentation, and feel free to, well, take your time. We don't, as Luis said, we don't have times or protocols. It's an informal, and the idea is to deep dive in the reliable information.
Thanks so much again, everyone. So can you see my screen properly?
Yes,
Yes,
perfect.
perfect.
Okay, perfect. So thanks so much again. And I'm Alessandro Feo, ophthalmology resident in Milan, Italy, and now retina fellow at UCLA in Los Angeles. And it's such a great pleasure for me again to speak about this advanced imaging technique that we love so much. And of course, I would like to thank you and to congratulate you as well on all your initiatives from retinography to orbit. And it's really a great honor for me to speak to all of you today. So the content of this presentation is actually from this recent article that we've published, that we have mentioned, and so this is the outline. I have segmented the presentation from the vitreoretinal interface through the choroid, so we will navigate through the middle retina and analyze also the outer retina and all the alterations that we can find in retinal diseases. We will start with the vitreoretinal interface diseases, moving to the middle retina and the retinal capillary plexuses, so retinal vascular disorders, to move then to chororetinal disorders, including age-related macular degeneration, pachychoroid. I will finally conclude with more miscellaneous diseases, including inflammatory disorders and more miscellaneous conditions. To keep it more interesting, I will also speak about two recent original studies that we've recently published using ANFAS OCT in epiretinal membrane and sniffer. If it works for you, I am extremely open, of course, to any type of question anytime, but it would be great to have maybe some questions at the end of each section. So after the first section, second section, and third and fourth question. Each section should have a duration about 8-10 minutes, but of course I'm open anytime to reply to any type of question that may arise from our slides. Okay, so why we are here today? So as you all know, ANFAS OCT is a very simple, non-invasive and fast imaging technique that allows us to actually visualize hypo and hyperreflective changes at target segmentation planes, and allowed us to have in vivo representation of retinal and choroidal tissues that were previously only identified by means of histology or electron microscopy. In addition, ANFAS OCT more recently also has an ultra-wide field capability that gives us the opportunity to have an assessment of retinal lesions of a very large anatomical area with a single acquisition. So starting with the vitreoretinal interface section, we will first focus about some biomarkers and then more on some more clinically significant disorders. So starting with a historical perspective. So epivascular glia was first described in the 70s and 80s by a couple of groups. It was defined like the presence of stellate retinal plaques and dendritic extension of glial-like cells through internal limiting membrane breaks. This is, on the right, a scanning electron microscopy image. And you can see that actually ANFAS OCT can extremely, with a very striking similarity, allow us to visualize these same lesions. These lesions were actually studied with ANFAS OCT in this paper, and the authors found a prevalence of about 9% of these epivascular glial lesions thanks to ANFAS OCT, which are especially visible thanks to a thinner slab at the level of the ILM. The authors correlated the presence of these lesions to more advanced PVD stages, hypothesizing that Mueller cells activate and extend dendritically along the retinal surface following PVD. A similar biomarker is represented by the presence of the white dot fovea, of foveal hyperreflective dots. Again, this is a electron microscopy image, and this is the zoomed image. And again, OCT was able to essentially visualize the same lesions non-invasively in this paper by Corradetti and co-authors. Another biomarker, another relatively older biomarker that was recently studied with OCT is the presence of paravascular inner retinal defects that were first identified again in the 70s and then that were studied by means of cross-sectional OCT by Hono Matsui and co-authors back in 2006. And then by Dr. Rosenfeld group in Miami in myopic eyes. More recently, Veronica Romero Morales and colleagues studied these lesions with OCT in a very large cohort of subjects, including healthy subjects, and they found a prevalence of these lesions in about 12% of eyes. Please keep in mind this lesion because we will talk about them in a few minutes. Again, the authors correlated this lesion with the presence of PVD, epiretinal membrane, and macular schisis. Also, the authors created a classification of this lesion into two grades, grades 1 and 2, based on the absence or presence of communication with the vitreous cavity, respectively, for these nerve fiber layer defects. OCT in the context of the vitreoretinal interface can also be applied to the study of macular holes, and in this context we can actually visualize the presence of retinal folds and retinal cleavage, and this actually allows us to have a different idea of the pathogenesis of this lesion, which is tractional in the context of tractional lamellar macular hole, therefore requiring potentially surgery, versus a more degenerative pathogenesis in the context of what they are called degenerative macular holes. Also, OCT is able to visualize different patterns of contraction and Henle fiber layer morphology in the context of a epiretinal membrane. In this recent study by Andragovetto and co-authors published in Retinal, we can actually see on the left a pattern of foveal ERM with a more regular Henle fiber layer morphology, which is actually correlated to a lower metamorphopsia score, versus a more distorted and extrafoveal pattern of contraction, which is actually correlated with more irregular Henle fiber layer morphology and higher metamorphopsia scores. Another very, very important OCT biomarker is represented by inner retinal dimples. These lesions typically develop after ILM peeling, especially after full thickness macular hole surgery, more than epiretinal membrane surgery, and they represent nerve fiber layer and also ganglion cell layer defects, possibly due to damage to the Mueller cell foot plates. These lesions appear as early as the first month after surgery, and increase in number and size during the subsequent 3 to 6 months. However, they usually tend not to progress beyond 6 months. And thanks to ANFAS's adaptive OCT, we can again visualize these hyperreflective dots similar to the white dot fovea, possibly indicating Mueller cell activation. Moving to another important biomarker visualized with OCT, this is the presence of nerve fiber layer schisis. This is relatively frequent in the context of epiretinal membrane, and is usually associated with ILM dehiscence of tears. ILM tears were actually described recently in this American Journal of Ophthalmology paper by Mark Johnson and colleagues, who used a multimodal imaging protocol, including essentially cross-sectional OCT, multicolor infrared. The authors found a prevalence of ILM tears ranging from 8 to 30% based on surgical or non-surgical indication, and they identified several associated biomarkers, including nerve fiber layer schisis, paravascular inner retinal defects, and inner retinal dimples. For these reasons, we designed, considering all these vitreoretinal and OCT biomarkers collectively and together, we designed this study to employ wide-field OCT for the first time and to study epiretinal members complicated by the presence of ILM tears. We included 101 eyes from 101 patients with epiretinal membrane. And we evaluated, of course, demographic and clinical data, but also the presence of nerve fiber layer defects, which were classified as round or oval. And round correspond to the presence of paravascular inner retinal defects because of their shape here, while the oval defects actually correspond to the presence of inner retinal dimples. Both of these lesions actually represent defects in the nerve fiber layer. We also evaluated the presence of schisis of the nerve fiber layer and also PVD grade. We found a prevalence of ILM tears in about 21% of eyes with epiretinal membrane, and we identified some statistical significance in this association. First of all, the presence of nerve fiber layer defects round, that is paravascular inner retinal defects, was significantly higher in the ILM tear group versus the non-ILM group. ILM tear group. This was also the case for schisis of the nerve fiber layer and grade 4 PVD. Importantly, the presence of inner retinal dimples was only detected in the ILM tear group. You can actually visualize in this wide field 12 by 12 ANFAS OCT image segmented at the level of the superficial slab, so ILM, the presence of these ILM tears, which are represented by these curvilinear hyperreflective lesions that correspond to this scrolled ILM edge here, the presence of horizontal schisis of the nerve fiber layer, and the presence of this oval, which is spurs and round paravascular neuroretinal defects at the level of the superficial slab. So we concluded that while paravascular neuroretinal defects likely result from PVD, from evolving PVD, the presence of inner retinal dimples in the context of ILM tears is likely associated with progressive epiretinal membrane contracture and ILM self-peeling in a similar fashion to ILM peeling causing inner retinal dimples after surgery. Just a quick mention also to the application of ANFAS OCT in the context of rhegmatogenous retinal detachment. In this context, ANFAS OCT can be used to non-invasively visualize the persistent subretinal fluid after surgery, which can be visualized as these hyperreflective blebs, and also the presence of outer retinal folds, which actually appear as these linear hyperreflective lesions at the level of the outer retina. But these lesions, thanks to ANFAS OCT, have been demonstrated to actually resolve usually during the first year after surgery. So this concludes actually the first part of my presentation, and I'm happy to answer any question that you might have so far.
Well, Alessandro, you make a great assembly of so many information and applicability and great images. One thing that I have in mind, ANFAS OCT exists since whatever, and I think that it gained attention. What take it to the spotlight was the OCTA. We need to check some ANFAS structural ANFAS to check the quality and artifacts, and you showed a lot of images. My question to you is, do you used to use some OCTA segmentation? Do you prefer in segmentation? In your practice, is there any segmentation for a specific disease that you think it's best to use in the daily practice?
Thanks so much for this question. I think this is the most important point, because segmentation is everything in ANFAS OCT. Of course, based on the symptoms of the patient, we can actually choose the first and most important segmentation, usually very, very easily, since we are talking about usually chorioretinal diseases. So AMD, I usually start by looking at the outer retinal. to see if there are alterations such as drusen or outer retinal alterations in general, including ellipsoid zone disruption. And then based on the presence of course, also looking at the cross-sectional OCT. So if there are microaneurysms or other lesions like CME or exudates, we can actually take a look also at the middle retina, so at the deep capillary plexus, that I show you very soon in the next section. And of course, if the patient complains about metaprophopsia or other symptoms, which can be related to vitreoretinal interface, it's also very useful to use the superficial slab. So usually I think that the automated segmentation provided by the different devices are good. And of course, we can actually also manually adjust the segmentation. For example, in these images that I showed you here, in these vitreoretinal interface images, these are actually manually segmented. This is about a slab of about 40 to 60 micron. And thanks to these lesions, actually, we can, thanks to this segmentation, we can actually visualize these lesions that can actually also be useful in terms of surgery. For example, in ILM tears are useful to grab when you start the peeling. So I think this is the most comprehensive approach that we can have by looking at each segmentation based on the patient's symptoms, and of course correlating it with the cross-sectional OCT, which is of course always fundamental.
Yeah, and it makes total sense when you check the ellipson first, or when you start by the deeper segmentation, you can identify shadows and hypertransmission defects, and it allows to exclude the further examination or to go deeper in the investigation. It makes total sense. Thank you.
Thanks so much. Okay.
Alessandro, sorry, I was mute. I have two questions. First, okay, the first one you just answered about the ERM, how to bring the emphasis to the practice. Like you said, you can grab, you can first grab the ERM where it's easier through the emphasis. I have another question. I don't know if you have worked on that, but I've seen before in a conference, I don't remember who presented, the emphasis following of a macular hole, because sometimes we see the macular hole closing, but then in a second time, you see the outer retina going closing afterwards, right? So you can follow the closure of the outer retina through the emphasis, despite the macular hole is still closed by the OCT. Have you done something about it?
Absolutely. Thanks so much, Luis. This is a very important point. I was actually unsure whether to include these slides or not, but for time reason, I just skipped them. But maybe next time we could discuss them. So, of course, emphasis is fundamental also in longitudinal monitoring of macular hole and the periatal membrane after surgery. I think also to reply to your question that emphasis OCT will be more and more used also to classify this type of diseases, because as you were saying, by only using cross-sectional OCT, we actually miss some information. That actually, thanks to emphasis OCT and thanks to this large view with a single acquisition, we can actually visualize the pattern of not only like the closure type, subtype, but also the presence of photoreceptor disruption, granular hyperreflective dots. There is a paper by Govetto and colleagues on this in American Journal, but also the presence of CME around the full thickness macular hole. So for sure, the application of emphasis OCT in macular holes is very, very, very important. And as I showed you also in the context of a periatal membrane, where we can distinguish foveal versus extrafoveal patterns, I think the same can be done with macular holes to actually study, for example, the extent of photoreceptors recovery in a certain, percentage of the hole, and so I think this is a very important application, and we are not studying that, but a very important application.
Thank you.
Well, Alessandro, we are always trying to make it practical for the ophthalmologist to tomorrow, in the next time that he sees a patient, he can apply it in the practice. So if you have any insights that might not be in your presentation, any clues or ways to make it easier to taking care of patients, feel free to acknowledge it.
Thanks so much. Thanks so much. Also, you as well. I mean, I'm learning from you, obviously. So I'm happy to hear that from you as well. So
Following the same line of thinking, there is many reading centers nowadays. They use the on-fast OCT to measure the area of the ellipsoid zone, for instance, for degenerative disorders such as retinosa pigmentar.
Yep.
So I remember that we used to make measurements of those ellipsoid area, because when you're measuring just a line, when you're using just a B scan or cross-section B scan, you're going to have, well, you're not going to have the whole idea of the whole extent of the ellipsoid zone. So I think there's something for you to follow the patient with those kind of diseases really important. And on top of that, for those kind of research when you're studying new drugs and etc.
Thanks, Eduardo. Totally agree. Actually, there are a few slides on quantification of ellipsoid zone loss with not only, as you mentioned, retinitis pigmentosa, which is actually really a very great application, especially for clinical trials, but also for macular telangiectasia type 2. Also for AMD, of course, in terms of geographic atrophy, since in the US there are therapies for complement inhibition, essentially. So that's a great point, and actually we have a few slides about that.
Can I ask a question?
Sure, Castillo.
Alessandro, this is Gabriel Castillo. He's a friend from Brazil that is currently in Cleveland Clinic researching too, and he is a rising star here in Brazil. We have a lot of publications together, and he will teach something for us today.
Thank you, my friend. So, Alessandro, first off, congrats on your presentation. I know you're not done yet, but this is as impressive as your manuscript. So I'm leveraging the Ricardo brought to light, the segmentation. From a research standpoint, how do you deal with the segmentations issues that we have mainly in wide slabs like 12 by 12 when you are doing research and the built-in software can't appropriately segment the OCT and FAS? But when you're dealing with like high volume exams, like you need to do a lot of images. How do you deal with that?
Thanks so much, Gabriel. So nice to meet you as well. So unfortunately, this is a limitation of on-fast OCT, especially as you were mentioning, where we need very precise and high volume scans, or in certain conditions, which can be myopia and high myopia, or when there are so high PDs, for example. In polypoidal choroidal vasculopathy, for example, there can be PDs that are so high. So it's very difficult to actually segment and have reliable information in these cases. The easiest way that I could think about is just to manually adjust the segmentation. So to point by point, select the layer that you're interested, select the thickness of the slab that you're interested in, and just go by there. But of course, this is a limitation, and I hope that software advancement will actually help improve this point. But actually, I think that the possibility to manually adjust the slabs and avoid segmentation artifacts is actually pretty easy. I mean, we're talking about a non-invasive imaging modality that doesn't require dye. It only requires actually patient collaboration, but it's not even so. Not even so long, just a few minutes. So. I mean, I think this is a great point, but I think that manual segmentation and adjusting point by point for each layer that we are interested in is the answer in these cases.
Awesome, thank you.
I have a point to add to this discussion. I'm really a fan of real life studies, and we know that
Yes, sir.
every diagnostic method has fails, and we just learn a lot with OCT and geography how to handle artifacts. So, Gabriel, thinking about researching a topic that would be very useful, not for identifying the pathophysiology of the disease, but uh, to introduce the application in the real life, is let the device do the thing and check how the capability of diagnosing and helping, and really the utility of the ANFAS of each segmentation. I think that it will be it will help more people. Okay, it's in my humble opinion. Alessandro, I think you should go. We are very interested, so I don't know how long you're planning, but we don't have time here. We don't have any schedule.
Amazing. We can keep forever, like talking about that. So okay, so if there are no more questions, I can move to the second part.
Yeah.
Okay, perfect. So let's now move to the middle retina and retinal vascular disorders. Okay, so before starting, just a very quick introduction about the capillary plexus. As you all know, the arterial inflow of the retina is mainly due to the superficial vascular complex, while the deep vascular complex is mainly responsible for the venous outflow. And especially the deep capillary plexus is especially valuable in the context of the inner nuclear layer. Infarcts at this level can cause PAM lesion, paracentral acute middle maculopathy. This is an example of CRVO, where we can actually notice the presence of these hyperreflective lesions at the level of the inner nuclear layer in a skip configuration. Using alpha OCT, at the level of the middle layer of the middle retina, we can actually visualize, also thanks to overlay of the arterial and venous vessels, this typical fern-like perivenular PAM pattern. However, this is not the only pattern that we can have in PAM, but we also have the so-called globular PAM pattern. This pattern is characterized by a continuous inner nuclear layer hyperreflectivity, in this case caused by a calcific embolus at the level of the inferotemplar retinal artery. The question is, can perivenular PAM progress to globular PAM? The answer is yes. In this example, after 5 days, this patient developed a complete central retinal artery occlusion with progression from perivenular PAM to globular PAM. This is actually an indication of the so-called ischemic cascade, which refers to the process where infarcts and ischemia progress from the deep capillary plexus vertically to the superficial vascular complex. It's also very important to understand which is the legacy of PAM lesion, and this is represented by ripples, retinal ischemic perivascular lesions. These lesions are defined by an inner nuclear layer thinning accompanied by an outer nuclear layer and especially Henle fiber layer expansion. These lesions are very easily identified thanks to ANFAS OCT segmented at the level of the middle retina as these hyperreflective lesions. These lesions are clinically important to detect because they've been associated with myocardial infarction in patients with coronary artery disease, but they also very frequent in patients with hypertension and diabetic retinopathy in up to 90% of cases. So the detection of ripples can actually lead the physician to suggest cardiovascular screening, for example, in these patients. in this non-invasive way. Another example of the application of alpha-OCT is the detection of the typical perifoveal petaloid hyperreflective lesion in the context of acute macular retinopathy, and also for the colocalization of this lesion with deep capillary plexus hypoperfusion, correlating these slabs at the level of the outer retina with the deep alpha-OCTA slabs. Also, just an example, in the very wide spectrum of Henle fiber layer disorders, this is an example of Henle fiber layer hemorrhage, which can be associated with a very heterogeneous spectrum of etiologies. And again, alpha-OCT can beautifully show the petaloid pattern of these hemorrhages at the level of the outer middle retina in these cases. In the context of diabetic retinopathy, alpha-OCT has many applications, not only from the detection of exudates, CME, but also microaneurysm. But in this presentation, I just wanted to highlight the possibility to visualize occult retinal neovascularization, which cannot actually actually be visualized in this ophthalmoscopy. But thanks to alpha-OCTA and alpha-OCT, we can actually very easily identify these lesions as these hyperreflective lesions with an extremely high sensitivity and guide treatment, of course, in these patients. Finally, alpha-OCT can also be used to monitor and to detect large retinal capillary aneurysm, which is a new nomenclature for which is a new OCT nomenclature for telangiectatic capillaries and peripheral vascular anomalous complex. Actually, TELCAP are a secondary disease to usually diabetes or retinal vein occlusion, while peripheral vascular anomalous complex are usually an isolated disease, unilateral and unifocal. But in these examples, you can actually see the presence of this hyperreflective ring with an hyperreflective lumen, the presence of hyperreflective exudate and CME, and actually the resolution of all these lesions after 2 sessions of macular laser. And this is another example showing similar images. As Eduardo was mentioning, the area of ellipsoid zone loss is becoming more and more important in the context of clinical trials as an imaging endpoint. Recently, intravitreal therapies have been approved by the FDA for Mactella, so this will be for sure a very important application. I'd like to conclude this session by showing you this paper that for sure you know. It's about the distinctive mechanism and pattern of intraretinal cystoid spaces with alpha-OCT. You all know that exudative maculopathies are characterized by a petaloid pattern due to the disruption of the inner blood retinal barrier, while tractional diseases are actually characterized by this typical radial spokewheel pattern. And finally, full thickness macular hole can have these sunflower patterns similar to what Luis was mentioning earlier. Of course, this is important to identify because in cases of exudative cystoid spaces, we should treat with medical therapies or intravitreal injections, while tractional macular cystoid edema should actually be treated with surgery when appropriate. So this concludes the second part of this talk, and then we could move to AMD and pachychoroid, if there are any questions now.
Well, I just loved it, your final explanation about the pattern in the cystoid space. We were just yesterday discussing about a patient. And we are trying to figure if this fluid or tractional, if it was exudative or tractional. And now I want to check again and look for it. Also, you showed the tail cap that I don't know. I'm Yes, nice to meet this new name. Yes, it's new for me, and I use every single case of in every single case of till cap, I use the unfast to check where it is and to measure the distance from the fovea to decide if I'm going to laser it or not. So for me, it's the best way. Everyone has an opinion, but I don't have to do any other scanning or dyes, and I have this information.
Totally agree, 100%. Like Anfas OCT for this type of aneurysmal lesion is truly the best in my opinion. You can actually visualize the lumen, the hyperreflective lumen, the ring, the distribution of the exudate, the distance from the fovea, which can actually not be visualized by cross-sectional OCT so well. And so totally agree, no need for dye injections in these patients.
Also, the injections have the leakage make it kind of fuzzy to identify some features, and then unfast you'll see it's clear, crystal clear. Anyone have questions, or should we move? Let's move.
Perfect. So let's move now to AMD and pachychoroid. So, okay, perfect. So in the context of age-related macular degeneration, Anfas OCT can be very useful to identify different subtypes of drusen and subretinal drusen deposits, aka retinal reticular drusen, and to follow them longitudinally. This is an example of a patient with multiple lesions. So you can actually notice the presence of these hyperreflective vitelliform lesions represented by the presence of SHRAM in the fovea, surrounded by soft drusen, and two different subtypes of reticular pseudodrusen or subretinal drusen deposits, which are actually represented by the dots and by the ribbons. The dots usually break through the ellipsoid zone. And you can actually visualize perfectly the pattern and extension of these lesions. Anfas OCT at the level of the outer retina can also be applied to visualize these lesions over time, but if we use a lower slab at the level of the choroid, we can actually distinguish also other subtypes of drusen. Soft drusen, usually due to their lipofuscin skin contact, create signal attenuation. So at the level of the choroid, we will actually have a dark signal, hyperreflectivity. While calcified drusen are actually interesting because they create a very nice donut pattern due to the very mineralized content of the core of this drusen that actually completely stop the OCT signal. The hyperreflectivity at the level of the margins of the lesion is actually nascent atrophy. Finally, cuticular drusen are characterized by a thinner RPE at the apex of the lesion, and therefore these lesions are actually characterized by a so-called reverse donut sign because of the hyperreflective core and hyperreflective ring. This is just a cartoon to summarize these differential optical properties due to the different RP and features and drusen content. It's very important, as Eduardo again was mentioning earlier, the quantification of geographic atrophy and hypertransmission defects, especially in the context of AMD. And actually, several studies have shown that atrophy as imaged with Anfas OCT is extremely comparable to atrophy image with the FAF, which has been considered for years the gold standard for geographic atrophy quantification. This is an example of a patient with a 4-year follow-up that had only a few drusen at baseline and some very small and hypertransmission defects. And actually, you can see the correlation between the Anfas OCT at the level of the choriocapillaries and the sequential tract FAF images to follow the development of these hyperreflective and hypertransmission defects and their progressive vicinity to the fovea. This is an example from a paper from Dr. Rosenfeld group showing that hypertransmission defect can actually be quantified, and so there is a great promise also in terms of clinical trials using ANFAS-OCT as an imaging endpoint to monitor geographic atrophy, especially with the recent advent of complement inhibitory therapies. In the context of pachychoroid, ANFAS-OCT can provide again a non-invasive alternative to dye-based traditional angiographic techniques such as ICGA. In this study by Prithviram tool and co-authors, we can actually see the illustration of imbalanced choroidal venous drainage patterns and the colocalization of choroidal vascular hyperpermeability as shown in these mid-phase and late-phase ICGA ultra-wide field scans with patterns of choroidal thickness map derived from ANFAS-OCT slabs of the choroid. Of course, ANFAS-OCT can also be very easily applied to central stereoscleral retinopathy to show the hyperreflective subretinal fluid, but also again with choroidal segmentation, all the alteration of the choroidal vasculature, importantly, even non-invasive manner. Finally, in this context, ANFAS-OCT can also be applied, of course, to the detection of polypoidal choroidal vasculopathy, as shown in this example, where the thumb-shaped PD appear again as a donut lesion in this context. So this concludes the third part.
Yes, I have a question, Alessandro.
Sure.
It's a show of images. Is the way we like to see a presentation, and I'm enjoying a lot. And I have one question and one comment. Is important because here in Brazil we don't have the medication for atrophy yet. Okay, but we are used to follow those patients through B-scan and FAF. Which FAF, I've read some papers showing that the FAF, like you said, is very similar to the ANFAS-OCT, which I don't completely agree, because ANFAS-OCT is better when you have medial opacities, and when the atrophy is close to the fovea in the FAF, the fovea is dark. So it's very hard to define or to delineate the margins of the atrophy when it's close to the fovea, which is not true for the ANFAS. Okay, for the ANFAS it's very easy; it doesn't bother to be close to the fovea. So to follow atrophy, and Dr. Rosenfeld is saying that about 10 years ago, ANFAS-OCT is much better, and we will have to learn how to use ANFAS-OCT because of the atrophy of the atrophic AMD. And the second question is, I love CSR is my main issue of research, and I'm not sure. I don't know if you have done some study or some research about the ANFAS characteristic or features of the choroid of these patients or not. Have you done something?
So thanks so much, Luis. First of all, I totally agree with your first point. It's true. Dr. Rosenfeld is a very, very supportive of this concept of ANFAS-OCT for geographic atrophy, and I think he's right. I mean, it's non-invasive, does not create discomfort to the patient, like FAF can do something, even though it's non-invasive. And regarding the second point, there are some studies regarding the different choroidal vasculature patterns in CSR. There is especially a study by Riccardo Sacconi and co-authors and Giuseppe Querque's group showing that there are some different choroidal patterns. There are, for example, the reticular pattern There is also the herringbone pattern. In the review, there is a little paragraph about that. And these patterns are actually more and more studied with ANFAS OCT. It will be interesting, in my opinion, to further study these patterns, also to understand if, for example, the presence of choroidal anastomosis between different drainage systems can be associated with differential lesions, for example, pigment epitheliopathy, but also CSR manifestations. And for sure, the main advantage of ANFAS OCT is its non-invasive nature. So we can actually repeat it as many times as we want, which is something that maybe with ICGA we cannot always do. And so for sure, I think it is a very great point. And there are a few studies, but actually ANFAS OCT in pachychoroid, I think it's still a relatively underexplored field. So it will be very interesting to apply this technique to further study this topic.
Thank you.
Alessandro, I think that it will be the only point that I can add something in this presentation, because I have a retina fellow. It is Jessica Galvan. I think she is here. I don't know. And we found in a few cases of central serous chororetinopathy, using ANFAS, the correlation of the hypertransmission defects with the leakage points in the acute phase. And we follow these patients, and we noticed that these hypertransmission defects closed after the resolution. Can you add something in this point? Do you know something to tell us? I think that she is preparing this paper, and I don't know if you have any comments.
Thanks so much, Ricardo. Great point. Actually, the main paper that I know about is the paper by Prithvi and two encoders that I showed you. But I think this is very important to actually, also as also Luis was mentioning, to study longitudinally these alterations. So actually, I'm looking forward to the paper. Congratulations to you and your fellow on this work, and so I'm very excited to read about it. I think it's a great point to correlate the hyperpermeability with ANFAS OCT choroidal maps, and would be very useful to non-invasively monitor these patients.
Alessandro,
Sure, Gabriel.
can you go back to the image that you're showing the GA, please?
Sure. This one?
Yes, this one. So I find this one very interesting because you're detecting GA and its progression by putting your segmentation, your slab in the choroid. So you can detect the hyperreflectivity. So I did see some manuscript detecting progression of GA, but selecting involving the slab in the RPE and EZ. So it's gonna be the opposite. So the healthy RPE would be hyperreflective, with the GI being hyperreflective. So two different manners to get the same result. But in your opinion, does one is better than the other or something like that?
Extremely important point, especially for clinical trials. As you all know, of course, the thickness of the choroid is different in patients. So in different patients. So we should actually very carefully adopt different slabs in the choroid to visualize hypertransmission defects, because there can also be the influence of the sclera in some cases for the hypertransmission. And I think that your point is great, because also according to the recent, now not even more so recent classification, the consensus from the CAM group in 2018 from Dr. Sada group. So in these cases, we should actually very carefully distinguish complete outer retina and RPE atrophy, so C-RORA from E-RORA. So, and this segmentation, thinner segmentation at the level of the RPE and outer retina are actually very important. There are a few papers. Actually, I was looking at them yesterday and today while I was finalizing the presentation that actually compare different slabs of outer retina, RP, and choroid to detect geographic atrophy. And there can be some discrepancies. So it's actually very important, in my opinion, to address this point and understand if actually there are significant differences. The truth is that, in my opinion, in my humble experience, the generalization are never the answer. So we should, and this is actually a generalization, but but the point is that we should actually very carefully address the single case of the single patient, because the RP status can vary very widely, very heterogeneously vary across different patients, even in the same patient in different time points. And this is important in the context of drusen. For example, calcified drusen, I showed you that they can have a donut pattern, but then when they become atrophic, actually, they become a very round hyperreflective and hypertransmission defect. So, and in this case, there was a donut lesion corresponding to a calcified drusen in the past, but now we are only visualizing the atrophy. So, I think that, of course, for clinical trials, there will be always limitations in this sense. It will be very difficult to address all these points for different patients. But I think that studies comparing different slabs for different lesions will be of very high value for future research.
Thank you.
Thank you. Okay. Let's, okay, perfect. Okay. Any other questions or comments?
I think we should go.
Okay, sure. So let's move now to the fourth and the final part of the presentation. I know it's a lot of information. I just try to give you an overview of all these conditions. So moving to uveitis and inflammatory disorders. So an example of ANFA-associated application is MUSE, multiple evanescent white dot syndrome. In this inflammatory disorder, which is usually idiopathic, we can actually visualize the presence of these hyperreflective spots and hyperreflective dots. The spots are thought to be related to a more distal photoreception inflammation. And that's for this reason that actually MUSE was considered to be a photoreceptoritis, so an inflammation of the photoreceptors. And while the hyperreflective dots actually might represent disruption or shed photoreceptor segments and Mueller cell damage. This is important because this lesion can actually resolve either with observation or with therapy. I just want to show you an example of a actual patient. So this was a patient with MUSE masquerader, which is in this case a syphilitic retinitis. And this is the baseline, the ultrawide field fundus autofluorescence, where you can see all the hyper autofluorescent spots in the macula and extending also in the mid periphery and far periphery. And ANFA-associated at the level of the outer retina, more specifically the ellipsoid and RP, shows the hyperreflective spots and the hyperreflective dots. The patient was diagnosed with syphilis and was treated with appropriate therapy. And you can see that the dots completely resolve, and also the spots tend to normalize in reflectivity. I'll show you again. So if you look at the zoomed circles, you can actually see the resolution of the spots and dots. And this can be a very useful way to monitor the improvement and the response to therapy in these patients. Another example of application of ANFA-associated in the context of inflammatory disorders is represented by placoid disorders. This is an example of AMPI, so acute posterior multifocal placoid pigment epitheliopathy, and you can see the presence of an ANFAS OCTA here, with segmentation at the level of the choroid capillaries, and ANFAS OCT at the level of the outer retina. You can see, focusing on this part here, for example, we can see that there is not so much hyperreflectivity in this circle, but with follow-up, this is actually a 2-year follow-up, there is progressive increase in choriocapillaries hypoperfusion, which is actually the driving pathogenesis of this condition, with development eventually of this choroidal neovascularization with Schramm and subretinal fluid. Coupling these ANFAS-OCTA slabs with ANFAS-OCT slabs, we can actually visualize all the outer retinal disruption characterized and represented by these hypo and hyperreflective alterations, but also the development of Schramm and subretinal fluid after almost 13 months of follow-up. This same concept of coupling ANFAS-OCTA and ANFAS-OCT can be applied also in the context of toxic maculopathy, for example, such as pentosan or Almiron maculopathy. And in these cases, we can actually see the progressive increase of the FAF alterations with 3 or 4 years of follow-up. And again, ANFAS-OCT at the level of the outer retina and ANFAS-OCTA segmented at the level of the choriocapillaries beautifully show the progressive increase in choriocapillary flow deficits, which is actually accompanied by this increase in the outer retinal alteration in this patient with pentosan maculopathy. Finally, and this is also to introduce the second original study of this presentation, of course, ANFAS-OCT can be very easily applied to visualize schisis, which can be idiopathic or can be, of course, secondary to tractional or other etiologies. This is an example of sniffer, so stellate non-hereditary idiopathic foveomacular retinoschisis, and I'm very excited to present also the results of these recent studies that we have just published in Ophthalmology Retina. So essentially, we use a multimodal imaging approach, including ANFAS-OCT, to describe the long-term clinical and multimodal imaging follow-up of sniffer, contiguous with mid-peripheral retinoschisis. Also, we described a new and relatively more severe variant of sniffer that we termed carpet, central anomalous retinoschisis with mid-peripheral attraction. This was a retrospective case series, including 15 eyes from 11 patients. Of course, we excluded other etiologies of retinoschisis, such as degenerative or exudative conditions, but also high myopia or glaucoma or other etiologies, and of course, also a family history of genetic abnormalities, which is, for example, X-linked retinoschisis. We evaluated the presence of progression, regression, or stability of mid-peripheral retinoschisis or sniffer over time, and these are the results. First of all, patients were predominantly female in accordance to previous sniffer descriptions. Mean age was 56 years, and the mean follow-up was 33 months. We detected the presence of progression of mid-peripheral retinoschisis in 5 eyes of 3 patients, so 33%, with very long-term follow-up. This is an example. So you can actually see that the fovea is not involved by the schisis so far, while the infratemporal mid-periphery is involved by infratemporal peripheral retinoschisis at baseline. Using ANFAS-OCT segmented at the level of the Henle fiber layer, in this case, and outer retina, you can actually see this pattern of schisis, which is temporal now in 2021. But with follow-up, we can actually see the involvement of the foveomacular region. That's why this patient developed sniffer. What's even more interesting, actually, is that waiting 10 more months, this patient actually regressed. So the schisis actually was starting to regress, and only a few cysts are left in the fovea, and so we observed a spontaneous resolution of the sniffer and mid-peripheral retinoschisis in this case, and this occurred in 2 eyes of 2 patients. Another example is shown here, where you can see the resolution of the schisis with the mid-peripheral schisis and also sniffer with long-term follow-up. Another aspect is stability. So sniffer can also be stable together with mid-peripheral retinoschisis. This is an example of 54 months. And again, you can visualize the typical patterns of sniffer in this patient with ANFAS-OCT. we also propose a novel sniffer variant that we term carpet. So this lesion, this disorder, and I thank very much Andrea Govetto for providing this case, actually for starting all of this description, is characterized by the presence of three unique additional features in addition to the fovea macroretinoschizis, which are the central neurosensory detachment that you can see here with the yellow asterisk, that together with the outer lamellar macular hole, and this very pronounced mid-peripheral traction, in this case at the level of the supratemporal arcade. Again, so this is the definition: central anomalous retinoschizis with mid-peripheral traction or carpet. And ANFAS-OCT in this case was useful to identify the vertical appearance of the Mueller cells using a segmentation at the level of the Henle fiber layer. So this patient was operated on by Dr. Andrea Govetto with 25 pars plana vitrectomy, and you can see the results. So after 1 month, there is an improvement, not only, of course, on the ANFAS-OCT images, but also of the cross-sectional, and with a complete normalization of the Mueller cells after 1 year. And the patient also improved dramatically in terms of visual acuity. I think baseline was around 20, 200, something like that, and final result was 20, 25. There is in the table of the paper. So this is another example actually of carpet. So central anomalous retinoschizis with mid-peripheral traction. In this case, ANFAS-OCT again at the level of the Henle fiber layer shows the full extent of the cystoid spaces and of the retinoschizis. Please note this nasal area of sparing, which is shown here, and along the infratemporal arcade, there is this evolving incomplete PVD with subretinal fluid. See what happens after just 2 months. So after just 2 months, there is a progression of the PVD and involvement also of the nasal area, as shown with ANFAS-OCT. There is also an increase of the central neurosensory detachment and an increasing development of these outer retinal macro, which are all characteristic features of carpet. So in conclusion, we showed that ANFAS-OCT is useful to demonstrate the progression of resolution or even stability of sniffer associated with mid-peripheral retinoschizis. We propose the existence of this novel variant that we termed carpet. And of course, there are some different clinical and therapeutical implications because sniffer can be relatively safely observed and only monitored without need for intervention, while carpet, which is more severe, more aggressive, with more pronounced mid-peripheral traction, can actually merit and deserve more aggressive and surgical approach to solve the schizis and improve vision. So this was actually the slides 99. I have slides 100 for the introduction of the conclusions. So I welcome any question now before moving to the conclusions.
Well, Alessandro, it's kind of breathtaking imaging, and well, I love retina imaging. You are aware of it, and these are really, really great. I have a question for you. I saw several ways of clinical application of ANFAS-OCT imaging, and I don't know if I missed something, but every ANFAS image that you show is based on the highest reflective point of the OCT image, correct? There are some ways of analyzing the lowest point of reflectance for each map, and we have a few papers studying this kind of ANFAS image, and for me it's kind of very interesting. do you have an experience or thoughts about looking forward to this kind of face imaging? Just to explain for those who are not aware, the face image can provide a map of the highest point, the brightest point. Well, the point that is nearest the white, but you can invert it and have the information for the lowest point. And in a normal eye, the lowest point, it might be in the nuclear layers. And we can have kind of a perspective of the outer nuclear layer mainly and fluids position. What do you think about this kind of imaging and the possible applications?
Thanks so much, Ricardo. Yes, this is a very important point. I think, yeah, this is an alternative way to look at unfast OCT images. I think their applications are very important in this field as well. You were mentioning also the possibility to use heat maps, and I think this is very useful, not only as I showed you, for example, in the context of pachychoroid disease, where we can correlate the thickness map of the choroid with hyperpermeability, but also speaking more, simply in the context of AMD, where we can actually use these heat maps to detect the drusen volume, which is a very important biomarker of progression from intermediate to late MD. Also, more practically, what I see in clinic is also the use of heat maps to detect non-exudative or exudative choroidal or macular neovascularization. If you use the heat map on a outer retinal segmentation, you can extremely easily and quickly visualize the areas that are more elevated, which are, of course, red in these heat maps. And so if you go with a cross-sectional OCT through these lesions, you will actually very frequently see a PD or a double layer sign or subretinal fluid. Anyway, something that needs to be further investigated with either cross-sectional or OCTA, for example, to detect networks of neovessels. So for sure, this is a very, very important application. I think that this type of applications will be increasingly also used in context of clinical trials.
Great. I will let you conclude and we'll jump for the discussion. I have lots of notes, lots of questions. I want to learn more from you, and I don't know. I think that we have some message. Murilo is asking you to publish an OCT atlas or something. He is saying that your images are very nice, and are some questions about software or hardware. Sorry, I don't know. We can look to this.
We can conclude and then we do the questions.
Yes.
Yeah.
Yes.
Thanks, Murilo, for this suggestion. Let's do an unfast OCT retinography and orbit atlas. Let's do it. So for the hardware or software, I don't have much experience, honestly. I think it depends a lot on the device. So I've no financial disclosure, but I'm not sure if I can mention anything. But
you can.
Okay, so we usually use the Solix here at UCLA with Dr. Saraf. So I have more experience with that. And I think it's great. I also know that Plex Elite is great. Dr. Freund, for example, in New York uses that. I mean, there are so many different devices. It's so interesting to use them. Each of them has, of course, advantages and disadvantages, especially in terms of the time-consuming nature. I think this is important, but also the ultra wide field capability and segmentation artifacts. I think these are the most important points with the different devices.
Do you have any experience with those new wide field OCT, like Dream OCT or Torn Pi?
Thanks, Eduardo. I don't have direct experience with these devices, but some colleagues and friends actually use them, and they tell me that they are great. They can be sometime a bit more tricky in terms of acquisition, but for sure, I mean, they're great. So they can visualize very, very peripheral lesions. And if the patient is collaborative, I think they can be very easily applied in clinical practice.
So I remember then there was a meeting here in which Heusman and we were attending to a course, and they had a dream OCT. And of course, it was a really short period of time experience, but I think that the segmentation algorithm, it's a little bit different. I think it works a little bit better, but of course, it was just a handful of patients that we tried as OCT. But I think that there'll probably be something different about the segmentation algorithm, which is I'm curious to learn a little bit more about it. But I don't have that much of experience with those OCT as well. It's way too expensive so far. I mean,
Sure.
Don't be humble. You can
conclude if you want to conclude.
Sure. I have just a couple of final slides. So, as we were mentioning at the beginning, we all know the advantages of ANFAS OCT, and as we discussed together, of course, ANFAS OCT can be also used to describe new diseases, new biomarkers, and it has, of course, emerging applications of clinical trials. But as we were just discussing 30 seconds ago, it also has, unfortunately, limitations, especially artifacts, its cost and availability, but also, unfortunately, the absence of possibility to detect vascular leakage and provide dynamic information. This is especially important, I think, in inflammatory disorders more than others. So this is actually the only point, and I think that in the future it would be very interesting to actually address this limitation and possibly correlate ANFAS OCT with leakage using, of course, dye-based angiographic techniques. So this is actually just a quick conclusion and summary slide about everything. Of course, I want to thank you all again. And this was amazing also. Thanks to my mentors, so David Saraf at UCLA, my professor, my director in Italy, Professor Mario Romano, all of you, and the beautiful Orbit and the retinography community. Thanks so much for having me today.
Alessandro, we are very pleased to have you here, and your presentation was great, as expected. And I think that I have at least, if I know my senior, Luis Rosman, he might have a note taken by pen in the paper, yes?
Yes.
And you can start.
No. My main questions I did during the presentation. You can start, then I'll see if I have time.
Okay, Alessandro, I'm passionate about ANFAS OCT. I use it in my daily practice. I use the forum software, and I can cross all the multimodal imaging. And you said in your conclusions something like the limitations of the ANFAS images. Well, every image modality has a limitation. We are looking for a miracle or for 100% sensitivity and specificity, but it, it just don't exist. And ANFAS images are one it can add some piece in the puzzle when we are looking for the diagnosis or the best care or biomarkers. But as any other imaging modality in retina, it won't have, won't be it won't be the standalone technique. I don't know if you agree with me. I don't know a standalone technique for evaluating any retinal disease and grading and making us uh, taking the right choice for treatment. And one thing that I think we might aware for who is watching and want to apply it tomorrow. In OCT, we always think about the application tomorrow, the next day, few days later, and one main point is the segmentation. The segmentation is how the device names uh, the lines that will separate that scan. So you told for us that you use the Solix. I don't know if you have any material or information about the exchange about the different devices or hardwares. For instance, the Cirrus from Zeiss that I use, they call ellipsoid zone or EZ, ISOS,
Yeah.
a scan that they start in the RPE. They make the anterior and the posterior boundaries line from the RPE. So if you don't have the ellipsoid zone in the correct place, you will find something different. I don't know if you get the idea or the intention, but are you aware of any way to make a correlation within the device?
Great point. I think it's possible. I don't have so much experience in this sense. Most important, I think, is the thickness of the slab. And as you were mentioning, to be sure what we are referring to. So what we talk about when we look at the ellipsoid zone or inner nuclear layer, superficial slab, also vitreoretinal interface slabs. All these slabs can be subjective to subjective interpretations. So by different softwares. I think this is a very important limitations also for research and original studies, because it's difficult to collaborate with other centers that have different devices. And so it's difficult to acquire and collect data, for example, on geographic atrophy or hypertransmission defects or drusen volume and so on, in terms of using different devices across different centers. That's why standardization in this field is so important. So yeah, absolutely, it's a very important observation.
Also, we have discussed about the artifacts and the limitations of each method and the need to a comprehensive interpretation of the images.
Yeah.
In the paper, you mentioned that we presented the blue light reflectance imaging. We found um, we found very useful information from a no-cost method. However, this method has limitations, and we aim to enhance the understanding about how to make a decision if this information is reliable or not. I think that regarding face imaging, it's kind of the same, but we are so aware nowadays about artifacts during OCT and OCTA acquisition that it is more intuitive to understand this artifacts. That's why I love face imaging and why I use it a lot and talk a lot, and also it's the reason that I sent you a text. Can you send me your full text, please? It was the start of our discussion. There are some new technology for CT devices, and Heidelberg has the HD OCT that I'm not sure, but I think that they have 2.2 micron axial resolution. Also, we have some researchers using the visual light OCT that states that they have 1 micron axial resolution. And my question for you is, do you think that face imaging will be better or will get more information from this kind of new technology, or do you think that the spatial resolution is the main point of face imaging?
So I totally agree with you in terms of advancements in technology. I mean, they will be the most important development, and in several points. First of all, in terms of speed. So how fast we can scan the retina of the patient. So this is very important in terms of cost and availability. So the more we use face OCT across the globe, the more we are able to collect data, study new biomarkers. Of course, also in terms of segmentation. So we need a standardization. As you were mentioning, and I totally agree with that, a multimodal imaging approach is now essential in every retina clinic. I think very practically, if we have a fundus photography, if we have an face OCT and OCTA machine, which can actually show us a face OCT, a face OCTA, and cross-sectional corresponding scans. And if we also have the possibility to perform angiography, I think we are done. I mean, our patients rarely need something more. Of course, also fundus autofluorescence and other techniques. But I think that face OCT, of course, it's not a miracle, but it does have some limitations. But I really think that for me now, it's I mean, it will be very difficult for me to practice without face OCT. So I think this is the main point. You know, it's also a sort of dependence.
I get it.
I totally agree. And you know, face is not built alone. You have the face, you have the B scan,
Yes.
and maybe you have the OCTA together. So you know, it's already multimodal. You know, it's born like this. So
Exactly.
Just one more question. I don't know if you are researching about it, and well, it's kind of a curiosity. The face imaging represents several points in a axial resolution in the axial X, and we have some digital information that goes from 0 when it's black and 255, I think, when it's white. My question to you is, we have layer by layer information. quantitative information from an OCT unfast map. Do you know, or are you researching some kind of artificial intelligence assistance for diagnosing provided by this means, or do you know any research? Do you think it worth to research to look for it? What are your thoughts?
Thanks, Ricardo. Yes, I agree. I think that especially as shown in terms of geographic atrophy and also ellipsoid zone alterations over time with quantitative measurements, it will be more and more important to apply also artificial intelligence softwares to study these patients with unfast OCT. I think that there is still room and there is still space for that in the literature. To the best of my knowledge, there are a few studies, but not so many. And it will be very interesting, for example, to ask the most common softwares that we use on a daily basis, such as, for example, ChatGPT or DeepSeek or others, or Gemini or others, to simply ask, this is an unfast OCT image, what is that? And see how these systems reply, and to see how reliable they are, to see which is the percentage of error. I think there is a lot of room for this type of studies. There are some studies that, for example, combine cross-sectional OCT and OCTA for detection of a wide spectrum of macular diseases. For example, macular neovascularization, but also AMD, also epiretinal membrane. There are some studies about that. There are not so many studies about unfast OCT. I think as we were discussing briefly earlier, it would be interesting to do that with different softwares and to see which is, the most reliable. To the best of my knowledge, usually the agreement it's not so high across different softwares and devices. And also this type of artificial intelligence systems perform well, but not yet at the level of an expert physician, of course. I mean, I think that, and this can be my opinion and my experience, I think that the best they can achieve is around 60 to 80%, not more. It's very difficult to go beyond 80 or 90% of reliability and accuracy. So hopefully, if we can train, artificial intelligence systems to detect better and better diseases, I think this would be a game changer. So absolutely. What do you think about that?
Yes, I think that we have to learn, such as we learn English and learn how to analyze a retinal imaging. I think that we have to learn how to talk with the artificial intelligence to get the results we are expecting. There is a new language in the world, and this new language is prompt-based. We are not prepared to do this. The idea is to make it simple for us, but in my opinion, we have to talk for the machine understands us. But it's a huge topic for us to discuss in a Tuesday. Alessandro, thank you so much for your time. I don't know if you are hurry or if you can take a time for look for the questions. What do you think?
Thanks so much. Obrigado. Thank you.
Alessandro, thank you very, very much for your presentation. It was brilliant. The images were fantastic, and our work is based on image, so it was really, really enjoyable to see your presentation and learn from your research. We hope that you continue doing the unfast research, which is very important for us. And it was really our pleasure. Thank you so much.
Thank you, Luis. Thank you, everyone. It was my absolute pleasure.
Well, we had hundreds of viewers in this live, It will be also available online since tomorrow. The thing that I want to share with them is it's very, very tough. It's hard to publish in progressing retina and eye research. It takes lots of time life for who are in the front, in the first author and writing and make the handwork. And I truly congratulate you for your job, your work. It was great, as I mentioned to you privately, and I take this space and this live to say to you, keep doing this great work. Truly. Thank you very much, Alessandro.
Thanks so much. Thank you so much, really.
For those who want to get in touch with Alessandro, we will share his social media and LinkedIn profile, and I'm sure you will be back with us. If you have any topic that you think it might fit, just message me or Luis. It would be great.
Whenever you like. Thanks so much.
Thank you.
Thank you very much.
Thanks so
Bye-bye.
much,
Bye,
Alessandro.
Alessandro. Bye. Bye,
Pleasure.
everyone.